Okay, now it's time for the Achilles tendon.
For Achilles, you simply slide around the corner like so. Now in this case, everything's the same. Patient position is still prone, foot off the end of the table. Landmark is still going to be calcaneus, but in this case it's going to be the posterior calcaneus. The movements again are going to be slight movements medially and laterally until you see the entire width of the Achilles tendon. The movements also are going to be some slight angulation until you get the tendon nice and bright along with the bone. And the area of interest is going to be between the skin and the calcaneus. That's your Achilles tendon. Now, it's also worthwhile noting that most of the pathology of the Achilles tendon is either going to be directly at the insertion or it's going to be a few centimeters proximal, what we call the mid portion of the Achilles tendon.
Okay, now it's time to draw it. So let's get cracking. So this is bone. There's your calcaneus, your posterior calcaneus. Now there's no cartilage in this view. Fluid, well, there's only a hint of fluid here. And this is what's called your retrocalcaneal bursa. There we go. Now there's also a bit of fluid here, and I've gotten in the habit of calling this the retroachilles bursa. However, I think there's other names in the literature. Actually, you should probably do it a bit more like that. Okay, what do we need to do next? Ligament, well, there's no ligament in this view. Tendon, now there's a massive massive tendon in view here, and that is, of course, your Achilles tendon there. Muscle, there's no muscle in view here. Now, it's worthwhile noting that there's something called the Cadaver's fat pad. And again, I'll co-opt the yellow for this. But this whole thing is a fat pad, really similar to the Hoffa's fat pad. So it's just here, Hoffa's fat pad, similar to the Hoffa's fat pad in the knee. So let's clear that away. Let's do it one more time. So bone. Do that a little bit better this time. Bone, cartilage, nothing. Fluid, a bit of fluid here, and a touch of fluid here. Tendon, for sure, that's tendon there. Muscle, nothing, but then we'll complete it by drawing the Cadaver's fat pad, which is deep to the Achilles tendon. There we go. Okay, now let's see what it's like. Now let's see what it's like in a live patient.
I'm going to show you how to scan and inject an Achilles tendon. Patient position is prone. The landmark is going to be the posterior calcaneus. The orientation of the probe is long on the lower leg up towards the knee. You can see the yellow arrow is currently inside the Achilles tendon. Now, for PRP, if there were a tendon lesion, I would simply place the PRP inside the tendon where that yellow arrow is. However, for cortisone, I would go deep to the tendon into the Cadaver's fat pad about here. Now, there is some disagreement about doctors about the safety of the Achilles tendon and cortisone. I fully agree, we would never put cortisone into the Achilles tendon. However, many doctors, in certain cases, will put a small amount of cortisone deep to the Achilles tendon in the Cadaver's fat pad just here.
Or the retrocalcaneal bursa.
The angle of entry would be like this. We would spin the probe 90 degrees, and for cortisone, we would place the needle entry like so, and touch the yellow arrow. And for PRP, the needle entry position is the same. However, the target is within the tendon itself. And that's how we scan and inject the Achilles tendon.
Excellent. Now time for the quiz.
Hey, congrats on finishing that section. Can I show you inside one of our live courses? Let's go.
I certainly can say that Frank's courses are very well structured, very well taught, very practical.
Just even being able to use ultrasound in like the top 25 conditions are the ones that we see in clinic.
There's a huge community and a huge well of knowledge when you join one of the courses and you have access to all of these people who have seen a lot more than you have, and there's no guesswork. You leave feeling very confident with what you need to do to be successful for your patients and then in your practice.
You want to be able to do basic hip injections, shoulder injections, elbow injections, and I think Frank Johnson set up a very good protocol and a very good syllabus to be able to get the top type of procedures you're going to be doing in clinic and make sure you understand those well before moving on to the next step.
My revenue went up almost instantly. There's always now just more opportunity to reinvest into my clinic, reinvest into the things that I like, and I've been very satisfied.